this is really, something somewhat atypical in my opinion. If you look at his history, this is a patient who presented with what I would define high risk by NCCN guidelines, just by virtue of a PSA over 20. But, he had a T2 tumor, obviously, and a Gleason score of 4+4, 8. Now we're calling Gleason, we're moving away from Gleason and we're using the grouping classification. So he had a group 4. That makes him a high-risk patient, obviously, and the standard of care for those patients is quite simple. In the absence of metastatic disease, those patients can actually be considered for local definitive therapy with the potential of cure. And most of those patients will either undergo surgical intervention with a radical prostatectomy and a lymph node dissection, or if the choice is radiation therapy, then patients will undergo radiotherapy with androgen deprivation therapy. The standard of care for most men with high-risk disease, when they elect to undergo local definitive radiation therapy, is to use radiation in combination with androgen deprivation or suppression of testosterone. And the standard guideline for most of us is to support 24 months of suppression of testosterone. So what is uniquely interesting about this patient is during his androgen deprivation therapy, he had completed radiation therapy. And during his first 6 months of therapy, his PSA did come down. Surprisingly to us, didn't come down to undetectable. Most people, one would expect to become undetectable within the first 6 months or so. Those are the people who tend to do the best, in my opinion. However, his PSA did come down to about 11 or so, but shortly after, his PSA started rising. It is very important to remind our audience that one of the fundamental keys here is to make sure that the patient has a testosterone suppressed level. Once you define that, you can actually make the determination whether or not the patient has developed castration-resistant disease, which is very simply defined, is actually any rising of your PSA, symptomatic progression, or radiographic progression, but in the context or in the setting of a testosterone suppressed level, which for most of us is under 50 nanograms per ml. I know there's some pockets of data in the Europeans often like to see testosterone levels less than 20, but most of us in our guidelines, actually we use T level less than 50. So with that, the patient actually obviously hits that definition of castration-resistant disease. It also happens that this particular patient had developed symptomatic progression by virtue of his intermittent back pain, and his bone scan, restaging by virtue of his PSA coming up. Oftentimes what we tend to do is repeat staging scans to demonstrate that the patient has not developed progressive disease, objectively speaking. Sadly, in this case, the patient had progression disease, at the level of the lumbar spine 3 and 4. So we have a patient with metastatic castration-resistant disease, has some degree of symptomatic progression, right, by virtue of his intermittent back pain. So the bigger question for us is what to do for these patients.